Thank you for joining us live this evening for our webinar on insulin injection technique and why that matters. I'd also, right at the beginning of this session, like to thank our sponsors because without them we couldn't have held this webinar, and they are B. Braun, GlucoRx and Owen Mumford. So thank you very much. So just as an introduction, we hear a lot about insulin products and devices and a lot about insulin safety, as you may have seen this week in the headlines, but we hear relatively little about how important it is that insulin is given correctly. So just for some basic housekeeping to start with, during this session your sound will be muted. So please can you ask any questions using the question and answer button. If you put them in the chat line, we won't be able to read them. So you do need to use the question and answer session. At the end of the session, if you'd like to email Laura Payne, that's laura.payne at ojpr.co.uk, you will be able to access a certificate of attendance and an evaluation form. So without further delay, I would really like to welcome my fellow co-chair of Trend Diabetes and ITM, and also the nurse consultant for Medicus Group of Practices, Debbie Hicks. Debbie has been the lead for injection technique for very many years, and we're delighted to have her with us tonight. So with no further ado, welcome Debbie, we look forward to hearing from you.
Good evening everybody. So it gives me great pleasure on this beautiful evening to welcome you to this session, and we've roughly got about 30 minutes of presentation, and then we've got at least 10 minutes for questions and answers. So please, if there is anything that you want to ask, please do feel free to put that down in the Q&A section, and we'll try and get through as many as we can. So what I'd like to do is show you what we're going to discuss in the next 20 to 30 minutes and look at how injection technique really does matter to ensure that somebody with diabetes who needs insulin therapy to get the best optimum outcomes. And so you can see here I'm going to spend a little bit of time on the background and discuss what is glycemic variation and what causes this, and as healthcare professionals and as people with diabetes, what we can do to resolve this and obviously reduce the glycemic variation that occurs on a daily basis. And then we'll finish off and then we'll open up to the floor to actually answer any questions that you have. So I'm not going to go through this step by step. You can read this quite easily, but there are a lot of people in the UK now that have diabetes, and you can see equally there's a lot of people that now require insulin therapy to treat their diabetes. And so you can see it actually works out to around 1 million people, but that's the total number using injectable therapies, which also includes the GLP-1s. But obviously we've got an increasing prevalence, and as people are diagnosed with type 2 diabetes at a younger age, then obviously they're going to live with their diabetes longer and consequently may need insulin at a later date. And we do spend a significant amount of money on insulin. So we want to make sure that really the people with diabetes are getting the best possible effect of these medications. And so as you can see there, insulin prescribing now accounts for nearly 40% of that overall spend. But what is glycemic variation? do we actually know what we're meaning, and do people with diabetes understand this? Well, of course, everybody has glycemic variation. It occurs in everybody with diabetes, but even those without diabetes. Unfortunately, those with diabetes do need medication to manage this glycemic variation, which is caused by many factors. And of course, we all know that long-term hyperglycemia, which is indicated to us by a HbA1c result, unfortunately puts people with diabetes at a marked increase of risk of long-term complications. So what we really want to do is reduce the glycemic variation, because actually we now know that nerve cells are particularly sensitive to high glucose levels, which causes the awful problems with, neuropathy, but also it creates a barrier to actually getting a good glucose target without increasing the risk of hypoglycemia. So I took this diagram from a study that was actually done by Ian Cranston down in Portsmouth, and this really just shows us how much the glucose levels fluctuate. And this was the same person, and this is their weekly graph of their glucose variations, and you can see there's lots of hypos, but equally there's lots of hypers. And although you can see the median tracing within the middle of this graph, you can see how much data there is to actually try and understand how we can best help people with diabetes. And it's a minefield when you're just looking at glucose variation, but it really shows us that even within the same individual, they can have very different days in the same week. And somebody who is not professionally active now, but Professor Edwin Gale was really on the money when he actually said this quote, and he was a particular hero of mine, because it was when PowerPoint presentations were starting to come in, and I remember distinctly saying that you're going to be very bored with this presentation because all my slides stand still, because at that time we had people that was whizzing things in from the left and the right and up and down and all sorts of kind of things going on in presentations, but thankfully my slides do stand still. But he's quite right that we can give insulin, but are we giving it at the right time, in the right way? Because actually, if we're not doing it all correctly, then how do we expect people to have blood glucose control that's within target? So I've just put some ideas together as to what causes glycemic variation, and these are the things that really we should be checking as healthcare professionals. So we need to explore things like medication, like the injection sites, like the actual injection technique procedure. We need to look at the insulin and also the equipment that we're using, but also, do the devices meet the needs of the individual people with diabetes? And of course, we can't do any consultation without we look at the food and the activity, because all of these things are going to actually have an impact on glucose control. So if we look at the effects, they can be quite extreme. And if we start with hypoglycemia, we all know that if somebody is having frequent hypos, then there is often weight gain, because they're actually taking in a lot of calories to get rid of those low glucose levels. But also the impact is that they're actually quite fearful of further hypos, and this can often lead to unplanned admissions, which of course is very expensive. But there's also hyperglycemia. So there's not only weight loss, but there's also the increased risk of long-term complications. And then if you've got glucose levels that are bouncing around from, 2 to 20 on a regular basis, it generally makes you feel pretty unwell. And of course, a poor HbA1c would tell us that glucose variation is, having an impact on that individual. But sometimes, because the HbA1c looks relatively normal, it can actually mask these wide ranges of glucose levels that somebody is actually experiencing. And then, of course, as I've already mentioned, there is the issue around long-term complications, especially around the microvascular and macrovascular complications. So, what can we do to help people resolve this glucose variation? Well, there's quite a few things, and I want to go through the list with you in the next few slides. So, injection technique is crucial, and I have no doubt that this is something that we kind of took for granted until I went to a meeting in 2009 and realised, even though I'd been nursing a long time, and also I'd had type 1 diabetes myself for a good few years prior to this, I realised how much I didn't know about the impact of poor injection technique. But of course, these are the things that we have to be aware of so that we can share this information with people with diabetes who need to inject. But of course, one of the major problems with poor technique is lipohypertrophy. And I'll go on to explain that a little bit more in detail as we go through the slides. But if you look at medication, and I'm looking at injectables in this particular instance, we've always got to check, is the person taking it? And that's almost a fundamental question that we have to ask. But is it actually being taken at the correct time? Is that the reason why the glucose is going up very rapidly after food? Has the insulin been taken at the wrong time, so it's causing hypoglycemia? And is the dose correct? But what we need is evidence to actually make that decision as to whether we need to change the doses, or in fact whether we need to change the type of insulin, because as you will have heard at the last webinar that we did on insulin safety, there's over 30 different types of insulin that we've got available to prescribe. But as healthcare professionals, we've got to have a pretty good grasp of how that insulin works with the duration to know which type is actually suitable for which individual. But also, we've got to think about, what does the person with diabetes who injects need to know? Because we need to make sure that when we do regular reviews, we're actually checking, does the person know about needle size? Do they know about the resuspension of the insulin? Are they doing an air shot? What about their sites? Do they inspect them themselves, or do they think that's our job? And are they using the right device? And crucially, is the insulin stored in the right way? Because insulin, although it's a very stable product, it does have to be stored in the correct temperature range to be effective. And of course, thinking about not only ourselves, but other downstream workers, are we disposing of sharps safely? So this diagram will be very familiar with you because it is actually within our Injection Technique Matters resources. And you can see there from the diagram that these are the sites that we would normally recommend. And for those of you who perhaps may have not seen these before, then I will show you the resources and how to get you know, your hands on those at the end. But if the person is aware of the sites that are most effective for absorbing the insulin, it means that they're going to get the best optimum use of that insulin. But we do need to teach people about lipohypertrophy, because that in itself will actually impact on the absorption of the insulin, and essentially can cause problems with both hypoglycemia and hyperglycemia. But why is it important to only inject in the subcutaneous tissue? Well, there's lots of evidence available, but I'm sure that this is very straightforward, because if you actually was to try and inject insulin into bones, it would be extremely painful and the insulin would not be absorbed adequately. But conversely, if you was to actually inject into a large blood vessel, then that insulin is going to be taken up very rapidly, and not only causing severe bruising, but potentially causing severe hypoglycemia. Now, again, if you're looking at pain, then if you was to inject into a nerve, then it would be extremely painful and potentially could damage that nerve. And again, if it was to inject into muscle, then it's going to absorb the insulin more rapidly than it would if it was in the subcutaneous tissue. And all the pharmacokinetics and pharmacodynamics have all been done with insulin that's injected into subcutaneous tissue. So it's really important that the correct injection sites are taught from the very beginning. Okay, so needle size. Actually, a 4mm needle is the shortest needle that we have available, and that's in pen needles. And actually, there is no evidence to suggest that any person with diabetes who injects needs a needle any longer than 4mm, because that is sufficient to get through into the subcutaneous layer and deposit it in the right place. However, if you look after children or you have slim adults, then unfortunately there is still a risk with a 4mm needle. So in those type of people with diabetes, we should really be advising the use of a 4mm needle, and that's really just to reduce the risk of an intramuscular injection. But site rotation is really important as well, because site rotation is one of the causes of lipohypertrophy. And you can see here just one of the sites that we've used to illustrate this. And really it's trying to give people an idea of how to not overuse sites. And so you can see here with the abdomen, if you think of it as an oval shape across the abdomen with the umbilicus in the middle, it's actually divided into 4 zones. And within each zone that could be used for a week, you would actually advise that somebody would inject into one zone for a week, making each injection about a finger width apart. And that way there is a lower risk of any lipohypertrophy actually occurring. And again, all this information is available in our resources. So if you want to get access to them, all you need to do is actually contact your local representative from any of our sponsors, and they can provide them for you. Okay, so how can we actually ensure that people who are injecting get the most out of their medication? Well, again, lipohypertrophy keeps coming up, but really this is a significant problem in many people, and there's been quite a lot of research done into this. And some of the major studies that have been done across the world, in Spain and Italy, and there was one study done in the UK that actually showed us that there's many more people with lipohypertrophy than we actually know about. And that's because they don't know it's a problem. You know, these lumps, they accept as being part of having diabetes and needing insulin. But, you know, we should, as healthcare professionals, be checking for this. And really, we should be doing this on a regular basis. But more importantly, we should be teaching people who inject to do this for themselves, because we know that actually lipo is very common. And if people are using a favourite site, which often does occur, and I'm sure that you've seen it yourselves in gentlemen, that, you know, you they can open their shirts at their abdomen, and they've got these two quite nice lumps that you could easily get a hold of, because they can easily open the shirt to do a lunchtime injection without causing any problems. But obviously, after time, those areas will get overused and they actually will sustain lipohypertrophy. But also, if they only use a small zone within the injection area, again, that overuses the site and makes it prone to lipohypertrophy. And another thing that we know can be a causative factor is reusing needles. I'm sure you've seen diagrams or photographs of needles that have been reused. And when a needle is used for the first time, it has a blunting effect because the needles now are very, very fine. But once that needle has been through skin once, it almost has like a little hook on the end. And of course, all needles have got lubricant on. So once that lubricant has been used by injecting for the first time, it's no longer available. And what happens is microtrauma occurs at the site. I'm sure you're all aware, insulin is a growth hormone, and that makes the fat cells within the subcutaneous layer grow in size, and that actually causes the lipohypertrophy. So it's really important that people understand that there's different causes that make those fatty lumps. At the moment, we don't have any real evidence for lipohypertrophy caused by GLP-1 agonists. But here's some examples of lipos, and you can see the one on your left is the one with the typical gentleman injecting at each side of the buttons of the shirt there on the abdomen. You can see in the middle one, it's the same person. You'll check that it's the same pair of underpants. But that lumpy area on the inner thigh must be so painful. I can't imagine why anybody would be, you know, encouraged to do that. But then you can see on the third slide, that is gross lipohypertrophy that's actually being caused over years of injecting into the thigh. But this person didn't actually accept that there was anything wrong there, which is strange but true. So what we have to do is we have to show people how to self-examine, and this is just a way of doing that. And as I say, everything that you're looking at on the slides is within the ITM resources that I'll show you at the end. We want to make sure that at the very beginning, but at regular intervals when people are injecting, that they know how to inspect their injection sites. And we actually teach them by demonstrating this. And this is how I would do it if I was looking to check for lipos in a person. And yes, I'm lucky. I do have an examination couch in the room that I use. And so I would always get somebody to lay down, because lipos are not always the same size, the same consistency, and they're not always on the surface of the skin. So you do sometimes have to palpate quite deeply to feel. But again, this is all available for you to have a look at in more detail when you have got chance to see the resources. But we really need to make sure that the person themselves actually looks at their size each time they give it. And, you know, they shouldn't be injecting into lipohypertrophy. They should be taught how to avoid using these areas, possibly for 3 months, but often for a lot longer. And make sure that the person has got the shortest length needle for their needs. Some people do prefer a longer needle, but there is no evidence to suggest that, you know, if you're overweight, you need a longer needle. If you're small or frail, you need a different type of needle. Skin thickness is the same for all of us, regardless of race, gender, age, or weight. But for insulin to work correctly, it needs to be stored. And one of the things that I am quite hot on is asking the person who's sitting in front of me who is injecting, what type of insulin are you taking? Tell me the name. Have they got an insulin card that actually they carry around with them? Because all the insulin companies provide the insulin cards now. Really, we should be making sure that people have them as part of the insulin safety checks. But equally, finding out whether they're storing it correctly. And although we haven't been able to go abroad as often as we used to because of COVID, we need to make sure if the insulin isn't stored in the fridge, then it is actually only used for that 28 days or for a month once it's taken out of the fridge. And also we need to check that it's within expiry date, because often if the insulin has expired or hasn't been stored correctly, it's not going to work as the manufacturers actually say it will work, and that can be a cause of glycemic variation. But also we need to look at the injection device that's being used, because if it's a syringe, and thankfully not many people are needing to use insulin syringes now, but is it an insulin syringe? Have we checked that? And if the person is self-administering the insulin, are they able to draw up the correct dose? Do they need help? Have they got visual problems or dexterity problems? And if it's a HCP that's administering, are they using a safety engineered needle device? And if so, have they been trained how to use it? Because safety engineered devices are great, but if you don't use them correctly, it can mean that the needle actually leaks, and that means that the person doesn't get their full dose. So again, the training is really important. And I've just got two of the available devices here, but it really is now important that these are available from whoever is employing you as a healthcare professional. And it should be the first line choice for people like community nurses or people who inject that have small children at home, or perhaps they're not able to get access to a good sharps disposal scheme, or perhaps there's somebody that has HIV or Hep B or Hep C, or if children are injecting it in schools or maybe in care homes or prisons. So these are really important issues that we need to think of because we want to protect the person with diabetes, but equally we want to protect that healthcare professional to administer it safely without the worry of needle stick injuries. And of course, the thing that really drove this was the EU Directive 3210, which we converted into UK law in May. And basically what it said, every employer should have a risk assessment for all situations where there's an exposure to Sharp's injury, and obviously should make sure that all their caregivers, as well as downstream workers, have access to safety engineered devices. So if you haven't got access to a safety engineered device, then perhaps you need to go back to your occupational health and ask the question as to why. And I know June sat there, but I know they had an issue in Leicester because Leicester was a little bit slow at getting the safety engineered devices in place. And I think they had to move pretty quickly when they were challenged about it. So please do challenge your occupational health if you haven't got access to them. And of course, ideally, it shouldn't just be your infection control staff that are looking at safety devices and which ones are suitable, but it should be the people that are using them that also get access to the choice, etc. But under no circumstances should be needle recapping. And actually, if we're doing an injection correctly, then we should be taking the Sharps box to the bed or to the patient in a care home or their own home to make sure that there's no way of dropping that Sharp or, you know, anybody else coming into contact. And of course, all Sharps injuries have to go through your local policy as it sits at the moment. I don't know what it's like for you. I know in Scotland they have very difficult situations, and a lot of people in Scotland don't have access to an actual Sharps disposal scheme. In Enfield, we're very lucky. We still have access to a Sharps collection service, which at the moment is free of charge to anybody that registers with our council. But who knows how long that will stay in place. As I said, we can't do anything regarding glucose variation without we actually look at food and activity. And again, it's looking at, you know, is the person giving the insulin at the right time? What's their dietary intake like? Are they doing regular activity? And is there any relationship between hypoglycemia and unplanned physical activity? These are all things that will help us to understand whether the insulin dose needs to be changed, or in fact, maybe the insulin type needs to be changed. So there's quite a lot to think about, isn't there, when we're actually looking at why people's glucose levels are varying so much on a day-to-day basis. But I think without we check these kind of things, we're not going to get the full picture. So we're at the end here, and I just would like to say that really this is very cliche, but prevention is far better than cure. And so what we have to think about is encouraging people to not inject into lipos. We want them to monitor their blood glucose levels frequently, but crucially, if they are going to move sites to use a healthy site, then we have to make sure that that insulin dose is reduced, usually by 10 to 20%, to make sure that we're not going to cause any hypoglycemia by the insulin being absorbed as it should. And of course, we need to encourage the optimal site rotation, try and get somebody to develop their own rotation scheme. And often make use of a wider injection zone than perhaps just that small area at either side of the button on the shirt. And we want to make sure that we don't get the body injecting into muscles, because again, that's a major risk for hypoglycemia, and often can precipitate unplanned admissions. We should be discouraging needle reuse. It's very difficult because people think they're saving the NHS money, but we really don't want people to reuse and risk, trauma at injection sites, bruising or pain when, the needles are relatively cheap nowadays. And also we want to discourage people injecting through clothing because, as I mentioned, these needles are very fine now. They will actually kink and lose the lubrication going through skin. So imagine what happens to them if they were going through denim or other, kind of types of clothing. It's going to make those needles less effective. So please do ask if people are injecting through clothing. So in summary, I'd like to suggest that glycemic variation is common. It's got a very different level of causes, and it can affect the person with diabetes in many ways. But what we want to avoid is making sure that the glucose levels are more stable. We want to prevent unexplained hypos. We want to prevent the unsightly lipos, and actually, by ensuring the correct injection technique is used, we can actually reduce the total daily dose of insulin without compromising the HbA1c level. And again, there are studies to show that if you actually use the correct injection technique, you can reduce the HbA1c by about 5 millimoles per mole, which is pretty close to some of the oral medications that we've got access to. So, it is effective. And also, if we can encourage the correct injection technique, we can actually reduce the cost to the person with diabetes through avoiding all these effects of poor injection technique. But we can also reduce the cost to the healthcare system by reducing unplanned admissions and, the potential for long-term complications. So you might have thought at the beginning, well, why is injection technique so important? But I think I've given you a pretty good reason for now thinking, actually, it's more important than we give credit for. So thank you for listening, and it's over to June now because she's been keeping an eye on the questions and she's going to try and help me answer these questions that you've had. So I hope it's been useful, and thank you to our sponsors for giving us the opportunity to do this.
So thank you, Debbie, for that really comprehensive summary of injection technique and why it really does matter. Now, you've got a really good audience who are asking lots of really interesting questions. So I'll start straight away because we've got quite a few. Now, 2 questions actually related to injecting into the arms. One said, is it okay to, because a person with diabetes had been admitted to hospital and the nurses on the ward said you can't use arms. And another one has asked whether it's better to use the back of the arms.
Okay, so thank you for those questions, whoever you are. I've actually got the resources on the screen now, and it just happens to have the injection sites there. And yes, you're quite right. You can use the back of the arms, but actually, when you're self-administering, it's very difficult to get round to the back of the arms. And so that's why when we're teaching injection technique to people who need to inject and can inject themselves, then I would actually avoid the arms unless they're able to lift the arm up like this and do it underneath. I'm not sure whether you can see me actually demonstrating that, but you would need to use the underside of the arm where there actually is more flesh. The worst place to inject is literally to go straight into the muscle here, because if you're somebody not like myself who works out and actually does have a good muscle, there's a risk that you can actually get it into the bicep and it's not going to be absorbed properly in there. So, you know, it really is for third-party injectors like healthcare professionals. Then yes, you can use a lifted skin fold on the upper surface of the arm. But if you are actually self-injecting, it's much better to lift the arm up and inject from underneath. We certainly wouldn't advise somebody to put their arm against a door jamb and push the arm, you know, kind of across the door jamb, because actually all that you're doing, you're moving the muscle as well as the subcutaneous tissue. So we don't teach that anymore. It's really using the back of the arm as opposed to the front. It's much safer.
That's great. Now, quite a few questions about the size of the needle. So one of our listeners is saying, is 5mm the smallest needle, or is there a smaller one? And I know you've mentioned one, so I'm sure you're going to talk about that. And then there's quite a few questions about the use of syringes. So if you've got a syringe that's already got a needle attached, they've usually about 8mm. Now, one of our listeners is saying that in their trust they've got some that has a 13mm needle. So could you just give us some information about that?
Yeah, so the shortest needle that is available is a 4mm needle, and all of our sponsors have 4mm needles available for pens. And there's very few cases that you will get an insulin syringe without a safety guard on it. If you're working in a hospital situation, all the syringes should have sharps guards on them. The hospital shouldn't be buying syringes without them on now because of the EU directive. The reason there isn't any smaller needles than 4mm is because the needle has to go into a bung, whether it's in a cartridge or a vial. And if the needle was to go into the bung with a smaller needle, you wouldn't necessarily get the insulin out of the vial or the syringe, because the bung is probably 2mm in thickness. So the manufacturers will be able to tell you much better than I can that the 4mm needle is probably the shortest needle that we're going to get to give insulin via the subcutaneous tissue. As far as I'm aware, there is a 6mm needle on an insulin syringe, but I'm not sure that that's available in the UK. Again, check with your rep from any of the companies and they will tell you. But the evidence that we've got, and this was a massive study, and it was actually performed by BD across the world, showed that actually the depth of the needle actually increases the risk of intramuscular injections tenfold, and it's worse in children. So if you use a 12mm needle in a child, then it's about 98% of those injections will go into muscle. That's horrendous. That just leaves me absolutely cold. But even if you use a 4mm needle in children, there is still a 25% risk of causing an intramuscular injection. So you can see why, even with a 4mm needle, we say that you must use a lifted skin fold to reduce the risk of the insulin going into muscle. So there is no reason to use any needle longer than a 4mm needle, because that will get through that 2.3 millimeters of skin to get in that subcutaneous layer. Doesn't have to go deep into the subcutaneous layer, it just needs to get in there, and it will be absorbed as per manufacturer's suggestion of time action profiles.
So we, just keeping on that point for a minute, we've had a query about whether if somebody's big, so they're overweight or obese, they should have a longer needle. And I know you've just talked a little bit about that. Could you just emphasize that? Is the skin thicker in people that are big?
No. There is no evidence that skin thickness varies between race, gender, weight, or anything. There's nothing, unless they have a particular skin condition, but there is no evidence. And there are studies, and there is the references in the back of the best practice guideline. But when insulin goes into the subcutaneous tissue, it doesn't go in as a bolus. So it goes in and then it kind of almost like a starburst, like a firework goes off. It actually, you know, goes between the cells. So it's not kept in a bolus, and it doesn't have to be deep into the subcutaneous tissue. It will work regardless of the thickness of the subcutaneous tissue. So no, it doesn't matter how much subcutaneous tissue you've got, as long as it gets into the tissue, then it will work the same.
So just some queries on special groups, really. So we've had a query about whether you would advise a lady that's pregnant to inject somewhere differently, or what advice would you give about injections for that?
Yeah, that's a good question. Obviously, you've got to be careful as the pregnancy progresses. Obviously, as the lady increases in size, then it definitely isn't advisable to inject into the abdomen. If somebody wants to inject into the abdomen, then they really need to go to the sides of the flanks. But that wouldn't be advisable, say, in the 2nd or 3rd trimester. We would try and advise a pregnant lady to perhaps use the thighs or even the buttocks. They may need help as the pregnancy progresses to twist to use the buttocks, but certainly you wouldn't be advising. It's not that the needle is going to get into the, you know, to cause any harm to the pregnancy, but it's just that the skin is very tight and it possibly is more painful. But again, if you look in the guideline, there is a particular section on pregnancy and the advice is in there for you to have a look at.
That's great. Now, I've got a really interesting question here, and it's from one of our listeners, and they're saying they've been advised to inject a basal insulin into the legs and the bolus into the abdomen. Have you ever heard that type of advice before?
Yes, and again, you know, if you look in the guideline, it explains the difference between the actual absorption of the insulin in different areas. So the abdomen is the area that absorbs the insulin the quickest. Then you've got the thighs, buttocks, and then arms. So if you want to get the benefit of the bolus, short-acting insulin, then you'll get the fastest absorption from the abdomen. But what you've got to think about is that person going to be physically active when they have injected? So if you think about injecting into the thighs, you would have to be a little bit careful about injecting into the thighs if you were perhaps going cycling, because the action of the cycling means that the muscle under the subcutaneous layer is going to probably increase the absorption of the insulin in the thighs. The same as, you know, the arms could be, the insulin in the arms, sorry, could be absorbed quicker if somebody is doing weights or is doing swimming, because it's the action of the muscle contracting and relaxing that could actually encourage the insulin to be absorbed quicker. So it's really thinking about the individual, what activities do they do, and what is the action of the insulin doing. So, you know, if it's a basal insulin that you want to absorb gradually through the night, then yes, the thighs would be great. Yeah, it's about the type of insulin and the type of absorption that you're really expecting.
That's great. So just to go back on the size of the needles, because the question keeps coming back. So if you only use 5mm safety needles, we're asked whether you should use a skin fold. Is that right?
It depends again on the size of the person. So if the size of the person is, they're frail, they don't have a lot of subcutaneous tissue, then possibly a lifted skin fold is necessary. But if they have sufficient subcutaneous tissue, then no, you wouldn't need a lifted skin fold. It's about assessing the individual and thinking, how much subcutaneous tissue is there at the point of injection? Do I need to do a lifted skin fold?
So let's just go to injection technique. There's a couple of questions asking whether you still give the insulin at a 90-degree angle or 45.
Okay, so when I was first taught to give insulin, it was at 45 degrees. But when I was taught to give insulin, I was using a needle that was 18mm long. Now, you know, if you think about the size of that needle, it's horrendous now. And that needle had to be sharpened because it had to be used as many times as you possibly could without creating massive amount of pain. And for a child, that's pretty barbaric, but that was the case in 1972. Nowadays, the technique is at 90 degrees to the skin. So unless the person is very frail or has very poor subcutaneous tissue, then it would always be a 90-degree angle. But if they are very slim, if they are a child, then it would still be 90 degrees, but with a lifted skin fold. I hope that does clear up a few kind of misnomers, but that is still the current advice.
Okay, so you've got these great resources, and it doesn't, they're the only places on this resource that's showing at the moment that you would inject. So yeah. One of our listeners is asking if you can inject into the feet.
Ooh, I would say not unless you're feeling quite sadistic, because I would say, well, I mean, people will inject where they think is best for them, and that's really difficult for us to make changes. Like the guy who I showed you with the lipohypertrophy on his inner thigh. I've actually seen somebody at a dinner table inject into their intercostal muscles, which is very good for effect, but very poor for insulin absorption. I've often seen people use their thigh, their inner thigh, but also their calves. And again, that's not an area that's been studied. And if somebody is going to go walking or running when they've injected into their calf area, then that's not going to help the absorption. So, you know, these are the areas that have been well tried and tested. We know the absorption rates from these areas. And, you know, if somebody is rotating sites, there shouldn't be a need to kind of check out your own sites and be a bit inventive. But who knows, people will still do what suits them.
So we're also asked how long you need to have keep the needle in when you've actually given the insulin. And yep. I think you've got that in these resources, haven't you?
Yes, we have. You can see the actual resource in the middle, which is the toolkit for people who inject, and it's a trifold page. But if you open the pages up, there is actually how to use a pen device, and you will see within there, when you fully depress the dose button, you would count to 10. And the only reason we say count to 10 is to make sure that all of that insulin has flowed into the tissue and that you're not going to get any backflow of insulin. Because people do worry if they see a drop of insulin at the injection site. It looks a lot, and so they're worried that they're actually losing some of their insulin. But the actual amount is quite low, but it does look more than people expect. So it is really to make sure the insulin dose has been fully injected and that there's going to be less chance of seepage.
So Debbie, you talked about injection technique. You showed that lovely diagram, and we've had a query about how often should they use one of those quadrants. Is it a week or is it shorter than that?
Yeah, so you would use an area for a week at a time. So if you're using the abdomen, you would use a quadrant a week, but as I said, you use a different area within that quadrant. So we normally advise a finger width apart or 1 centimetre apart. And then if people use a segment each week, they're resting the other 3 sites on the abdomen, and then they're not kind of, because I'm not sure whether you've come across it, but when I've actually asked people about, you know, do they rotate the sites, they say, oh yeah, I do kind of this side of my abdomen one day, this side of my abdomen that day, that leg one day, that leg. And it's like, no, because that will affect the consistency of the absorption. So really, you want them to stick to an area, but you can see on the legs, you can actually divide the site on the legs into 2. So you can use an upper thigh and a lower thigh, upper thigh and lower thigh on the other. So you've still got 4 areas to use for the month. But it's really keeping sites consistent, so you then get the consistency of the insulin absorption.
So just a couple, I'm only going to answer a couple of questions, and then I'll just give some advice to people as to where they can get these resources.
Yeah.
So Somebody's asking if you can put a sliding scale, so that will be a variable rate insulin infusion on a person with type 2 diabetes, and I can answer that because yes, you can, and we do use them, particularly in hospital. We wouldn't usually use it in a person with type 2 diabetes unless they were starving for a reason, so probably after surgery if they were usually on insulin, so I can answer that. We're also asked if there's a special insulin delivery device that has like a voice meter with it, Debbie, for people that can't see.
There isn't an actual insulin delivery system with a voice that I'm aware of, but there are pen devices that have indicators on them as to when it was given and how many units were given. But as far as I'm aware, there isn't any that would be voice activated. So I think, I mean, when I was a district nurse, we used to have fixed block syringes. So the person who had difficulty seeing the dose could actually draw up the insulin and self-inject because the syringe was fixed at a particular dose. But actually, they weren't foolproof and they could be tampered with, and also the person wasn't sure whether there was any air in the syringe either. So I think if somebody truly can't see, then obviously the pens have all got the clicking mechanism as they're dialed up, and that is something that somebody could maintain their independence with, because one click is 1 unit regardless of what pen is available, but really that person needs to be able to check that the dose is correct to be truly safe, and we've got that information in our insulin safety leaflet, and also there is the different devices within the guideline that you can see. Also, there's other things that you can get if somebody is particularly needle phobic. You can get the eye ports, which can be used for 3 days to give the insulin into, and it just means that it's one kind of injection rather than 4 a day if they're using a basal bolus regimen. There's also the Tickle Flex gadget that goes onto the end of the pen, which is a bit like a spider, and the pen goes in the middle, and the little arms of the spider tricks the nerve endings in the skin to concentrate on that sensation rather than the needle point as it goes in the skin. They're available to buy if somebody is particularly worried about self-injecting, but I think if somebody's sight is really a concern, then they may well need some support to administer the insulin.
Yeah, so just a couple of things, Debbie. Pediatrics, they use 0.5 unit on a click, and some of the new higher concentration insulins now do 2 units on a click. So people, you need to know which pen you're using, and you need, particularly if it's somebody partially sighted and they're counting the clicks, to make sure. And Debbie, as you know, we've produced some tools that have given some guidance of that, which wasn't out when these resources came out, but that's quite important. So the biggest other question we've been asked is where to store insulin, and I'm happy to talk about that, give Debbie a break. And the pen that's in use can be out of the fridge even in this hot weather, but you don't want to put it on a windowsill or the car dashboard where it's really, really, really hot. So you just use your common sense, but generally the pen that you can use is can be kept out. Otherwise, when you inject and it's cold, it's pretty nasty. Other people have asked about other topics, and I think it would be really useful if anybody wants other topics to put it on this Q&A section so we know that. And lots of you have asked about where you can find the evidence for what Debbie's been talking about. And if you download these resources from the Trend UK website, it's all completely evidence-based. So if you need to take that to your trust, you can do that because the references are all in there. Isn't that right, Debbie?
They're all in the back of the guideline. I mean, yeah. The guideline is actually was aimed at healthcare professionals, but actually I've given the guideline out quite significantly over the last few months, and I've just got it on my desktop, and I send it to people that I'm working with, because it actually is very comprehensive, very practical, straightforward, and you know, it often answers most of their questions. Within the actual document is also a quick checklist that was produced by Jane Diggle to help us as healthcare professionals kind of think of the things that we need to be asking somebody, perhaps on an annual review or a review at any other time during the year. So again, that's within the guideline, and you know, if you want to use it, by all means do.
So just to close, and thank you for those of you who hung on a little bit longer. This talk will be on our YouTube station, for want of a better word, and the link will be put on our website. So if you want to use this for training purposes in your areas, that's absolutely fine. You just go onto YouTube, download it, you can use it for whenever you like. And thank you all for listening and for staying long, and it's been great to have you all there. A particular thank you to our sponsors, B. Braun, GlucoRx, and Owen Mumford, and also to Debbie. Thank you so much. You've been really informative, and the amount of questions shows just how interested people are. Thank you, and good night.
Good night, everybody.